Hi, everyone. Thanks for tuning into the Buzz Podcast presented by Quality Rehab Management, where we are dedicated to getting you daily information to share with your therapy teams, with your nursing home teams during the COVID-19 pandemic. Everything seems to change on a daily basis, so subscribe to the podcast, stay up to date. We are trying to get you information from the most reliable sources. But if you have a suggestion for a topic or just have a question, reach out to me. I'm your host, Casey Lee, physical therapist and quality clinical specialist with QRM. And we've been discussing over the weekend. Today's March 23rd, Monday. So all weekend and most of the day today, we've been discussing what documentation best practices look like for therapy teams in this crisis, because there are rules and regulations that we have to follow, and we also have to follow the guidance from the American Healthcare Association, which we received last week, guidance for therapy personnel in long-term care facilities. To keep COVID-19 out of our facilities and to reduce the risk of spread if it gets in, we need to stop shifting people around, right? We need to limit the number of therapists that are traveling between one facility and another, because that has been suspected, according to AHCA, as a mechanism of how this is spread. And so we're really trying to limit that, but we also want to ensure continuity of care. And that becomes a challenge because there's a barrier. We can't, if we're not shifting therapists around, we don't have enough evaluating therapists to complete 10th visits and therapist progress notes on site. And now we're trying to reduce staff. It's a barrier. It's a natural barrier that I'm sure everyone else is experiencing. And so because we knew this was a challenge for us, we're going to offer some options for that may work for your facility. If you're in a facility that has a full team, you've got your PTs, you've got your OTs and your assistants, your speech therapists, this is not an option for you, right? If you have a full team, complete your documentation based on your regulatory requirements. There's no need to make adjustments. This is for facilities and programs that are strapped for staff. They historically have shared therapists, and we are begging for the reduction of those practices to limit the spread of this virus. And these are the buildings that we're talking about, okay? So in order to ensure that we have uninterrupted provision of medically necessary services, essential PT, OT, ST services, right? We are essential. And to reduce and minimize the risk of cross-contamination, we're proposing the following documentation requirement modifications to impacted facilities only, right? If you are not impacted, let me just repeat that. If you have the full staff, continue with documentation best practices based on the rules and regs, okay? If you're impacted, here are some options to consider. Allowance for documentation of remote clinician assistant consultation to complete progress notes at different intervals with a clinician counter signature. So we're suggesting a remote completion. Clinician would complete a therapist progress report remotely after reviewing documentation, daily documentation from the assistant daily treatments, daily interventions, and that the clinician would review the documentation, consult with their assistant, and complete that progress report offsite. Now, guys, this is a huge responsibility on both the clinician completing the progress report and the assistant providing the source documentation and the consultation that's going to drive the completion of that therapist progress report. This is not, yay, I get to do my notes from home. This would be a huge undertaking for both parties, and really, we already document really well the what, the why, the how, the skilled services that we're providing, why they're medically necessary, tying it back to the goals. We already do a really good job of that, therapy team. So great job. But if this is your option, this is your only option, right? I'm only suggesting this is an option when you don't have another option. Then your documentation needs to be turned up from you're already at 100% looking great, you need to amp that up 150%. Whatever you were documenting before for your daily notes, we need more. Whatever you were putting in your clinical impression section and justification for continuation of services, clinicians before, you're going to need to be amping it up to 150%. It's got to be comprehensive, crystal clear, no question why this patient continues to require the skills of PT, OT, or speech if this is the option that we're going. So clinicians will need to review the assistant notes. So assistants, your time to shine. Write those beautiful daily skilled notes, tie it back to the goals, address every single goal routinely. Let those clinicians see the work that you're doing in your daily notes. And clinicians from there, you won't have the ability to see the patient to collect assessment data. You will not be able to complete objective measures, standardized assessments. You will not be able to do that. You can do it through your assistant, right? If there's a piece of the puzzle that's missing, when you collaborate over the phone with your assistant, you can ask for that puzzle, for the assistant to collect that puzzle piece for you. But you will not be able to perform that on-site assessment that we're used to. And so you're going to become a really good detective of reading the documentation and determining what questions to ask, what puzzle pieces you still need to complete the assessment and your progress report, to progress the treatment plan, to determine which goals require upgrade, which goals require downgrade, which goals are inappropriate, right? This is, of course, another great time to be discharging non-essential goals. We do not need to have plans of care with non-essential goals right now. And if you've identified that, this is the time to discuss that with your assistant and discharge those non-essential goals. But you only have those daily notes in this collaborative meeting with your assistant. So huge responsibility, but we are considering it as an option for buildings where you are strapped for staff or you have been asked to limit the number of floating staff between your buildings. So that is, we will still continue to have the supervised by statements required per state practice acts. That has not changed. Okay, so assistants, every single daily note, at least one procedure code needs to have your supervising therapist, supervising clinician's full name listed. And some other considerations just to think about is in this climate, and I think I've already highlighted on it, but I think it's just important to repeat that floating clinicians is not ideal right now. But, evaluations, new conditions, right? something that's just not going to change is our patients in long-term care facilities and new skilled patients coming into our facilities. So our long-term care population and our skilled population, there are going to continue to be new patients who need our services, right? So new evaluations are going to be on our list, and we will need to address them. So having a system in place to limit, as if you are somebody that, if you're an evaluating therapist who has to float because now you've got your, you can't do a remote evaluation. I have no way to suggest that. I feel real good about the suggestion of a remote progress note. I feel like we can do that as a team, collaborate with our assistants, collect the information we need from the daily notes. I don't have a suggestion on how to do a remote evaluation at this time. So that will require you to go to the site and possibly multi-sites to complete the evaluations to ensure patient access to the services that they require. They need the service. We have to complete that evaluation. So if you are in that position, follow all of the safety precautions. Keep hand sanitizer with you. Use hand sanitizer the moment you arrive. Go directly to that patient's room. Find out from whoever scheduled you for that evaluation, find out the location of that patient and make a beeline directly for that patient's room to complete the evaluation, and then complete the evaluation offsite. There's no need to go to the gym, grab a laptop. If you can complete that documentation remotely, then you're limiting your traffic pattern throughout the facility. So get the information from your rehab director. See if you can get access to the EMR or have the rehab director safely send you the patient information, if there's a method for that, or have a system of you getting that information in a safe manner without traveling throughout the building and increasing that risk of cross-contamination, okay? Because the evaluations, again, we don't really have a plan for that. There is no plan for that. We need you to do the evaluation to allow access to services, but that means that we will have therapists floating from one building to another. But it is going to reduce, it could be an option to reduce the number of floaters if we're not in the buildings every single day floating to complete 10th visit progress reports. Okay, so that's really what this discussion is about, is that reduction of the daily floating to complete a supervisory note that we feel can be accomplished through a documentation review and a consultation with your assistant. So thank you so much for reaching out with your questions. I've gotten a ton and I'm collecting them, and I'm got a weekly frequently asked questions pod planned for Fridays. So if you have a question, send it to me. It always makes the list. But if you don't know my email, it's clee@qrmhealth.com. And I look forward to talking with everyone tomorrow. Thank you so much. Take care.